Welcome, dear friends. I'm Dr. Manjunath, and today I have the privilege of talking to one of the most eminent speakers in entire of India, and that happens to be Dr. Jaydeep Choudhury, and he's an infectious disease specialist based out of Calcutta. So, and I have the privilege, and I'm extremely thankful uh, to to oblige my request to present something for my channel. And today he'll be speaking something about the rabies. So here we go. Over to you, Dr. Jaydeep Chaudhary.
Thank you so much, Dr. Manjunath. It's a pleasure to be interacting in a scientific platform. And of course, when the topic is rabies. Now, there are few factors why I selected the topic rabies. Number one, nowadays we are coming across a lot of reports of human animal conflict due to various reasons. Most of the time, children are the victim. There are many instances then even people are getting frequent exposure to pets because now the tendency of having pets is probably more. And more importantly, World Health Organization has accepted the fact that to control human rabies, we must have the One Health approach because we cannot segregate the human rabies from the animal rabies and from the environment. So the preventive approach and also awareness approach should be holistic, covering the environment, the animal world, and the human world, because these three aspects are inseparable. So that's why, while talking about the One Health approach, it's not only the control and management and prevention of human rabies, it's the control of animal rabies also, because until and unless the animal rabies is controlled, you cannot control human rabies. And there is an environmental factor also. We must be more aware that even while discarding the garbage, discarding the unconsumed food, we must be more aware because that's how the animals come into direct conflict with human. So this awareness is very important, and especially children. You just imagine a 4-year-old child going to school, and sometimes the child may be playing in the field or just waiting outside the school gate to get into the car, and inadvertently the child is exposed to an street animal, might be in the form of a minor scratch, because the children are often curious, they go very close to the animals, or there may be a lick, and that's an exposure. And the child might come back home and may not report the incidents to their parents also. So that exposure may go unnoticed, and it is an exposure. So this awareness is also important, that how to do it. Of course, pre-exposure prophylaxis of the children before they go to school or go out unsupervised is an aspect that we can think of and we can consider. But there is no as such guideline or recommendation about routine rabies pre-exposure prophylaxis. It can just come spontaneously, and as a pediatrician, we may suggest this to the parents also. Even those who are having pets, those children may be given pre-exposure prophylaxis also, just as a protection. And then the awareness about which animals can transmit rabies, which animals cannot. There is a lot of confusion. Many people think that dogs are the sole offenders, but no, all warm blooded animals may transmit rabies, including cats, including cattle, not talking about wild animals, the domestic animals. Probably the only exception, few exceptions, are rabbit and small house rats. Squirrel is a questionable. There are conflicting reports about squirrel, but probably squirrels are also not that offenders. Bat rabies is not seen in India. Birds and reptiles, they do not transmit rabies. So this idea is also important because some of the times the parents get very scared when a domestic rat also bites a child, but they can be assured, sorry, reassured that the domestic rats do not transmit rabies. Field rats, the city dwellers usually are not exposed. Field rats do transmit rabies. So this is the awareness part. So the rabies riddles, because rabies is a riddle to all of us. But what we are trying to achieve is we are trying to move towards one health. Now, the rabies prevention, how it all started, because people have been dying of rabies since ancient times. It's about 140 years back. This boy, on July 6th, 1885, Joseph Mister, received for the first time Pasteur's live attenuated rabies vaccine. How it happened, one of the local physician took the child to France after overnight train journey, and the vaccine was administered actually by this person, Jacques Joseph Grachia, because Pasteur was a chemist and he was not authorized to administer rabies vaccine. So he took the help of this physician to administer rabies vaccine. What happened, by the time the vaccine was used, Pasteur was not in a physical condition to do the active research. He supervised because by that time he had a brain stroke. So his two associates, Emile Roux and Charles Schimmerland, they actually did the research of the rabies vaccine. But credit must go to this person, Pierre Victor Gaultier, because he was the person who used to extract the virus from the dried spinal cord of rabies infected animals and inject it to the animals. And that's how Pasteur got the idea of live attenuated rabies vaccine. So this was a bit of history. But what has happened over the years, we have realized that it's the interplay between the environmental health, animal health, and human health. And that's how the concept of One Health came. But still today, even after 1.5 century of rabies vaccine development, rabies continues to be a neglected tropical disease. Though you can see a huge part of the world is endemic to rabies. Now, World Health Organization has taken this initiative to form the United Against Rabies UAR along with other leading health organizations of the world, and India has also initiated this process. The motto is Zero by 30, United Against Rabies Forum. So that's the motto. So WHO's 2021 to 2030 roadmap is to end human deaths from dog mediated rabies by 2030 because dogs are the most common offenders. Improving access to human rabies vaccine, then there is technical guidance and build the capacity for One Health workforce. Unfortunately, most of the days when we see the newspaper, we see lots of reported cases of rabies deaths and rabies infection. And most unfortunate, this is a very promising kabaddi player who ignored an exposure to a domestic animal, believing it to be insignificant, did not take the vaccine and expired. So there are so many reports. Until death, only 20 people have survived from rabies, and that too with severe neurological sequelae. Regarding the reported incidents and all that, what we were having till date are quite old literature, both initiated by Dr. M.K. Sudarshan and Madhusudana. It was 2007, 2008. But we have a later report that's very recent. It was published in Lancet Infectious Disease 2025 to estimate the burden of human rabies deaths and animal bites in India. And it shows that there are about 9 million bites nationally and 5.6 per thousand annual dog bite incidents. And that's quite significant. What's more worrying is that 1 in 5 did not receive anti-rabies vaccine. Half did not complete full course, and there were nearly 6,000 deaths over this period. So that's quite alarming, which could be prevented. So though there is a substantial decline, but still it is a challenge, and we have to take the One Health approach, as I was already telling. Regarding the animals, well, there are provisions of post-exposure prophylaxis like wound care, rabies vaccination, immunoglobulin or monoclonal antibody, and there are several recommendations by the veterinary bodies and also World Health Organization about management, but these are easier said than done, that we all know. And there are limitations because animal rabies cannot be diagnosed or detected ante-mortem. There are though some antigen test but that's also from the brain extract. So we cannot diagnose rabies ante-mortem in an animal also. And rabies vaccination of dogs remains one of the most effective strategies for preventing rabies in humans that did not be told. It's an inactivated vaccine, can be given IM or SC, but there is no clearly defined recommendation about site. First vaccination minimum at 3 months of age, then booster after 1 year and probably annually. But we have to remember no vaccine is 100% effective. And while adopting a dog, which is a very common occurrence nowadays, the puppy should be vaccinated at 3 and 9 months and then yearly, because puppies can also transmit rabies. An older dog, if adopted, vaccine on adoption and on yearly basis also. This is as per the WHO recommendations published in frequently asked questions. The Bharatiya Nyaya Samhita also, BNS in section 291, has stressed on the responsible pet ownership, because a pet owner can be held liable if their dog causes harm to another dog or a human. Now, regarding the wild animal vaccination, it's not possible to give them injection. So there's a provision of oral rabies vaccine, which is not available in India. It should be distributed in a bait along with some food for the wild animal, and it has to be given multiple times. So there are some recommendations. It's practiced in some country to control the rabies in wild animal, but that probably is some distance from what we can do in India at present. So discussing about the animals transmitting rabies, as a matter of fact, all warm-blooded animals, they transmit rabies. Probably dog is the commonest offender, as I have told. Possible exceptions are domestic rat, guinea pig, and rabbit. Squirrel is a doubtful. Usually they do not transmit rabies and there's no report also. Man to man, rare, except corneal transmission. Human bite not reported. And milk of rabid animal consumption, no reported case of rabies. And of course, virus is killed if it's boiled. Next. So, bitten by vaccinated dog. Now, this is a big question, though practically it's immaterial, because See, even human vaccines are not 100% effective, and rabies is 100% fatal. So you cannot expect an animal vaccine to be 100% effective. So vaccinated dog bite is immaterial. Post-exposure prophylaxis needs to be given. Provoked or unprovoked bites, again, it's a myth because the dog doesn't understand what is provocation, what is not. So provoked bite and unprovoked bite immaterial. Whenever one is unsure about the exact nature of exposure, one can apply a spirit. If it burns, then it's a category 3 exposure. Next. Incubation period, usually it's about 3 weeks to 3 months, but there are reports of as early as 4 days to as late as 3 years. Well, shorter incubation period, usually if the exposure is closer to the central nervous system, and particularly in children, then if there is large inoculum of viruses, even bites on hands, because there are excess innervation, it may quickly travel to the central nervous system. And this is a diagrammatic representation how the rabies virus travels through the nerves. Next. So why children are at greater risk? Short height, the animal's access to the head, neck, and face is more due to the shorter height. So shorter time for the virus to traverse. Children are tremendously curious about animals, no knowledge about outcome and danger, and often there is poor reporting of exposure to parents. Next. So this is the WHO category of bites: touching or feeding of animals, licks on intact skin. It's considered as no exposure, so no treatment required. The category 2 is nibbling of uncovered skin, minor scratches or abrasions without bleeding, or licks on broken skin. This is exposure. Vaccine should be started immediately. And if the animal could be observed, then vaccination may be stopped after 10 days if the animal is healthy. Any transdermal bite, scratches with bleeding, or mucous membrane exposure is category 3, where vaccine along with immunoglobulin or monoclonal antibody should be given. Now, bites of wild animal is always category 3, even if it's category 2, but it should be managed as category 3. And same is with immunocompromised individual, they should be treated as category 3, even if it's category 2. Next. So the basic do's and don'ts. Number one, most important step is the mechanical removal of virus from the wound by running tap water for 15 minutes. A soap may be applied, mild antiseptic may be applied, but the wound should not be touched, or never the irritant should be applied. Irritant should never be applied. Now, of course, further management we have discussed and we will discuss also. Next. Now, in category 3 exposure, we give immunoglobulin or monoclonal antibody also along with vaccine. The sole purpose is that we give the vaccine at 0, then 3, and then at 7. As per WHO, the minimum cutoff antibody level for protection is zero point 0.5 IU per ml. To achieve that, it takes about a week to 10 days to achieve that level of antibody. Till that time, the person is susceptible to rabies virus because there is no neutralizing antibody. That's why passive immunization by rabies immunoglobulin or monoclonal antibody is given till this vulnerable phase is overcome. The antibody level rises due to active immunization, and the person is safe, because incubation period may be as short as 4 days. That's why in any category 3 exposure, treatment with immunoglobulin or monoclonal antibody is must. Next. So this is the WHO recommendation that I was telling about, zero point 0.5 IU per ml. Next. Now, there are certain reports, even from India. You see a 3-year-old boy, category 3 dog bite in the right thigh, presented with progressive ascending paralysis, and finally succumbed on 23rd day. The child received 4 doses of ARV, but due to negligence, did not receive immunoglobulin. And the diagnosis was confirmed with negative body. So, this is the importance. See, this is from India. This is the importance of immunoglobulin. We just cannot ignore a category 3 bite. Next. Another report is there. You can see. Next. You can see this is a paralytic rabies following cat scratch and intradermal anti-rabies vaccination. So this, next please. So this was another situation. Next please. This was another situation where even cat may cause rabies. That's why I wanted to say. Now, here you see 5-year-old boy, category 3 dog bite in the left knee and thigh. Received wound hygiene, immunoglobulin, ARV in immunoglobulins inside the wound, but developed symptoms of rabies. People were discussing whether it's a vaccine failure. No, what happened? The child was thoroughly examined, and it was noticed that there were 2 additional category 3 exposure in the gluteal region, as you can see here, which were not infiltrated with RIG. So every child exposed should be completely exposed and examined for any hidden bites in the areas. Otherwise, it may turn fatal. Next. So, failure of post exposure prophylaxis may be due to many reasons. The most common is improper immunoglobulin use, not used at all, injected only IM. IM immunoglobulin is no longer recommended because it doesn't reach the site, because there is no viremia. The viruses travels along the nerves. So if you give IM, it won't reach the nerves. Not all bite wounds injected, as I have told. Sometimes the immunoglobulin quality may be poor or exceptionally large viral load that may overpower the immunoglobulins. If the virus is injected directly into the nerve, will travel very fast. And if there is deviation from the WHO recommended protocol. Late immunoglobulin, well, it can be given up to 7 days after starting ARV, because as I was telling, that the blood level of protective antibody doesn't reach before 7 to 10 days. So immunoglobulin can be given up to 7 days. Next. Here you see a 4-year-old boy, category 3 dog bite. See the gaping wound. How to decide about wound closure? You have to close this wound. You may close with loose sutures, but definitely that wound should be infiltrated with immunoglobulin or antibody prior to applying the loose sutures. And that's so important that first you see the child and suture the wound. That will be disastrous. Next. There are various immunoglobulins and monoclonal antibodies available: human immunoglobulin, equine, single monoclonal antibody, twin antibody. Now, all are comparable. Probably the pros and cons, I will come to the next slide. But now, as per WHO recommendation, the skin test is not mandatory, even if it's a equine immunoglobulin. The human immunoglobulin, equine, and various monoclonal antibody, the doses are different. One must be very sure and see the package insert before injecting, and all are safe. Next. So this is the new thing that we have got, the monoclonal antibodies. It is safe. It is non-human source. So it is easy to produce, and a lot, large volume may be produced also. Next. So when we face the situation of deciding between immunoglobulin and monoclonal antibody, probably monoclonal antibody scores over immunoglobulin, because number one, it's a non-human source produced by recombinant DNA technology, large scale production, and demonstrated to neutralize 25 isolates of wild type or street isolates of rabies virus, and efficacy is, of course, non-inferior. Next. So some points to ponder. These are some practical situations we might face: an obese child. A small category 3 exposure, excess immunoglobulin, because if you calculate as per as per the weight, the volume becomes large. But the uh, wound is small. So wound as much as possible locally only. No IM injection. Next. Infant with large category 3 wound. How to manage? Because infant, the body weight is less, volume is less. You can dilute it with 2 to 3 times with normal saline. But all the wounds must be infiltrated. That's important. Next. Now, if there is requirement of 1.5 vial of rabies immunoglobulin as per the weight, but 2 vials purchased, can we give the excess amount? Why not? No. If given excess amount beyond the recommendation, then it will interfere with the antibody response of the vaccines that has to be administered. So correct dosage is very important with immunoglobulin or monoclonal antibody. Next. Routine tetanus prophylaxis, well, it depends as per the vaccine status of the child. If required, should be given, but it's not a substitute for rabies vaccination. Next. Sometimes it happens, somebody has gone to a short trip somewhere. There is a category 3 bite on a visit to a remote place where vaccine is available, but RIG is not available. Definitely, other than wound management, vaccine should be started and rabies immunoglobulin or monoclonal antibody can be given as late as 7 days. Next. Some questions, typical situation. Category 2 dog bite, the child is on post exposure prophylaxis after category 2 dog bite. Again, bitten by a dog on day 6. What to do? Now, day 6, there is no adequate antibody level because it's a category 3 exposure the second time. So we have to start afresh. Next slide, next, please. It will highlight. We have to start afresh the post-exposure prophylaxis as 0371428 because we haven't achieved that adequate antibody level. So we have to consider this as a naive case. Next. Now, children play a lot with pets. They kissed mouth to mouth with a vaccinated puppy. What to do? Next. Well, it's a controversial. Theoretically, it should be post-exposure prophylaxis plus oral rinse with RIG. Next. Theoretically, it should oral rinse with RIG is required. As in any mucosal exposure, if it's an exposure to the cornea, conjunctiva, there should be rinsing with the RIG. Theoretically, but practically, though, it's a bit difficult. Next. Completed pre-exposure prophylaxis often gets scratches and bites, a very common situation. Within 3 months of post or pre-exposure prophylaxis, we need not do anything. So within 3 months, following a completed schedule, nothing. Beyond 3 months, any exposure, vaccine, 0 and 3, 2 doses. High risk situation like dog trainers, zoo workers, handlers, etc. Ideally, there should be yearly antibody test. If the antibody titer falls below zero point 0.5 IU, booster. Sometimes it's not possible, so boosters recommended every 5 years in people at less risk. So again, it's a very controversial issue when to vaccinate, how to do the test and all that, but this is the WHO recommendation. Next. Pre-exposure prophylaxis indications. Well, as per WHO, in the canine rabies endemic countries, if there is continuous exposure like lab personnel in research, frequent exposure like vets, others dealing with animals, forests, etc., infrequent exposure like garbage collectors, delivery agents, etc., pets at home and with neighbors, and also the higher threats like children, they should be given pre-exposure prophylaxis. This is what WHO says. And I think it's a very important point to consider also. Next. So this is also the ACVIP recommendation. It is only for high risk. Rabies vaccine can be given, and you are all aware probably of this. Next. Now, there were some issues about the WHO recommendation and the ACVIP recommendation about the dosage, number of dosage, but now ACVIP, next slide please, has also converted and recommended the 5 dose schedule as recommended by NCDC and all other authorities because India is an endemic country. So for post-exposure, it is day 0, 3, 7, 14, and 28. Though WHO recommends 4 doses, but Indian recommendation consensus by the AppCry, by the Consortium Against Rabies, NCDC, and ACVIP also are 5 doses. Next. So these are the usual schedules of the post-expert prophylaxis. I think we have discussed already. We can go to the next. This is the NCDC guideline. So this was the old and new, but now it is uniform as 5 dose schedule. Next. So one thing we must remember, rabies vaccine is the vaccine, only vaccine with no contraindication. Any age, any condition should be given. All brands are killed vaccine. Both 0.5 ml or 1 ml preparations are available. Any of the preparation may be given, should be given IM at deltoid or tri, never in the gluteal region. And brands ideally should be continued with the same, but if not available, we may change the brand also. Next. Of all the vaccines, there is hardly any difference. We can pick and choose whichever is available, any vaccine, and all are equally effective. And there is no nerve tissue vaccines available nowadays. So we are safe to use any vaccine. Next. Now, what happens? Somebody has missed the date. A child is on post exposure prophylaxis, say on June 5, 8, 12, 19, and July 2. Now has taken 2 doses, 5 and 8, comes for the third dose on June 15. When do we administer the fourth dose? What is most important that the first 3 doses should be completed within maximum 10 days. So that's very important. So even if somebody has come late, we must not delay the vaccine. So we must give the vaccine and continue the schedule as before. Next. Next slide, please. So a boy had category 3 exposure to a monkey on a jungle safari. What should be the management? Now, another is a child with ALL or chemotherapy was scratched by a pet dog. In both the cases, because first is a wild animal and second is an immunocompromised trait, so it should be managed as category 3 bite. Next. Now, as we know that we are always trying to achieve a better vaccine, a better way of protection. So there are a lot of vaccines under clinical trial, rabies vaccine, a lot of vaccines, but probably the most dramatic prospects that we are facing are gene for rabies virus glycoprotein incorporated in a virus vector, then cloning by reverse genetics, and also pan-lyssavirus monoclonal antibodies as an alternate to HRIG. But we have to wait for all this, as also there is a prospect of a broad-acting antiviral for post-exposure prophylaxis like favipiravir. But till that time, next please, till that time, let's be responsible, let's love the animals with care, and let's also care ourselves and also our children and be very responsible and very aggressive when it comes to rabies vaccination.
Thank you so much, sir. It was such a lucid and detailed presentation. Sir, I have some dumb questions. You can ask so.
Nothing is dumb with rabies.
Well, if any parent comes to me and asks, I am getting a pet, should my family be vaccinated?
Yes,
I'm planning to get the dog vaccinated.
yes, Of course, better to be safe, because as I have already told, that you cannot expect an animal vaccine to be 100% effective. You cannot expect. So definitely it's better to go for a pre-exposure prophylaxis for everybody. Now, regarding the booster doses, that's a controversial. That is very difficult to comment, because you might be getting repeated exposure. But if that pet is not getting exposed to street animals, then you may just wait. If there is a category 3 exposure, then only you give a post exposure prophylaxis. Category 3 exposure by the pet to the household people, then only you give a post exposure, two doses, 0 and 3. If it's a pet in a restricted environment, then probably regular booster is not needed. But pre exposure is definitely advocated.
So we come across the common questions of cat scratch, random cat scratches. And as you've told, even those ones need to be vaccinated.
Yes, of course, cat may also transmit rabies. That has been proven. Cats are many a times street cats roaming around. It's very difficult to trace them. Dogs are easier to trace. Cats are very difficult. So even if there is a cat scratch, usually cats do not bite. They most of the time they scratch. It should be managed just as a uh, rabies exposure. So there is no question of any leniency.
So there's this good old thought, if you get a dog bite or something, you wait for the dog to show up any symptoms and then vaccinate yourself. I mean, this is a question for the audience who are not very well versed with it. So what should be the answer from our side?
Theoretically speaking, what I have told is that the incubation period may be as short as 3 to 4 days. And once the dog develops the symptom, it may be too late to start post exposure prophylaxis. So, what's prudent is that you give the 0 dose, you give the day 3 dose. If the dog could be monitored and watched, then you wait till day 10. If the dog is well till day 10, then you convert these 2 doses of post exposure prophylaxis to pre exposure by giving a booster at, say, day 21 or 28. So it acts as a pre exposure prophylaxis because the dog is well. If the dog is unwell, then you continue the post exposure or the dog cannot be observed, then better to complete the post exposure prophylaxis.
What is the percentage of you know say non-asymptomatic dog? Like, so is that how common is that situation among dogs?
See, even the rabies among dogs, it can be dumb rabies or it can be quite violent rabies. So you cannot say a dog is behaving. Most of the time, what we think that a rabid dog will be very violent, attacking everybody, but the dog may just be dumb, may just lie down, may just avoid food. So that is also a symptom of rabies. And unfortunately, you cannot diagnose rabies by any blood test, even in animals. You have to take the brain extract only. So you can never be sure. You can never be sure so about the animal's behavior. So better to go for personal protection. It's always advisable.
Right. So you were mentioning some of the statistics of the dog bites. So the other day, there was a report in Bangalore. Nearly 2,000 dog bites happened in Bangalore alone. So if you look at the problem, so many of them get dog bites. But we really do not have do we really have that capability to manufacture that load of vaccines for our country?
You mean animal vaccine or human vaccine?
human.
Human vaccine, there's a challenge. You are absolutely right. Fortunately, we have many companies manufacturing vaccines, but often we know that some of the brands they go out of stock. That's why WHO has recommended the intradermal vaccination, but that can be only done in government setup where the daily turnover is high, because there you are injecting a smaller volume of the vaccine intradermally. But to practice it in private setup, there will be wastage of vaccine, because daily you will never get 10 cases of exposure to animals. So that's the way out. That's how the government has taken it up to utilize maximum the volume of rabies vaccine that are available. And that's why there is a lot of research is going on manufacturing the newer rabies vaccine that I just told. But of course, the manufacturing capacity should be increased, because there should never be a shortage of rabies vaccine. Otherwise, the whole effort of containing human rabies will go in vain.
Oh, that's the message for the audience here.
Yes.
So whether you have a dog, you have a cat, whether you have any other animal for that matter, pre-vaccinate yourself. So that's the message.
Along with that, along with that, I would also like to pass on a message that whenever there is exposure, be it a scratch, be it a bite, whatever it is, wash the wound 15 minutes with running water and soap. No need for any antiseptics, no irritants ever, but just running water 15 minutes with soap. And that will wash out most of the viruses very effectively. So even if you find it hard to access a facility for a rabies immunoglobulin, but wound washing is most important. I will just tell you a brief story. About 2 years back, I had a animal bite right in front of my house on a Sunday morning, and it was a category 3 bite
Hmm.
suddenly. And I had to struggle a lot to find a person to inject intradermal immunoglobulin on me on a
Oh,
Sunday morning. So this might happen to anybody, but wound washing should not be compromised. You try to get local infiltration as early as possible, definitely, but wound washing should not be compromised. That's very important step.
so the point here is no matter what the bite is, if it is a bite, treat it as a bite. Simple.
Absolutely. You cannot take a chance, because I have shown so many cases, and there are cases, there are reports also. You never know. You never know. It's not possible.
Yes, sir. Very true. I mean, it's so unfortunate that a couple of years back, a postgraduate student from Bangalore uh, died of rabies, and we could never find the source because he was never bitten. The exposure was never traced. So it could be
Yes.
just a simple lick somewhere, a dog licking you. You're feeding a dog, something licks you, an exposed hand. You never know where the thing is.
Yes.
So the prudent thing would be to vaccinate.
Yeah. I mean, there has been cases. I mean, I know that a, a couple of pet dogs, they were taken very good care by the family, adopted family. They were taking very good care. There were caregivers for the dog also. Now she took the two dogs on an evening stroll, and she was just talking over her phone. After returning, she discovered there is some bite mark on one of the dogs, and that she ignored, and that the owners also ignored. And later, after about a week, the dog became sick, and after about 2 weeks, the dog expired. And the specialist veterinarian, and the dogs were vaccinated, of course. These dogs were vaccinated. And the veterinary person, he came and he told that it's a clear case of rabies from all the symptoms. And all these 2 weeks, the adopted family, they were taking good care of this dog. And then they realized it was bitten by some stray dog while the caregiver took those two dogs for an evening stroll, because she was talking over her phone. Because how come otherwise that bite was there? So you see, these dogs were vaccinated, so you never know. And this family was scared because they handled this dog over the last 2 weeks because they were very attached to the.
Emotionally attached.
Yeah, so they were scared. So this thing might happen. Even a well cared dog, it might happen. You can never say.
Yeah, very true, sir. This video makes more sense because there is so much of fight which is happening in the legal tangle as well. We are not here to discuss about the legal tangles.
No.
We are here to discuss about the individual health, and that's what matters most when it comes to rabies.
Fact is that you love animals. Perfect.
We love it. We love
Animals,
it.
animals are lovable, but you take self protection adequately. If you are planning to handle animals, go close to them, then yourself you take pre exposure prophylaxis. Try to arrange vaccination for the animals. Yes, you feed the animals, but also try to arrange vaccination. So that's very important. That's how you can break the cycle, rabies cycle. So that's so important.
So there's this sterilization happening for the dogs as well. So do you think will it curb any of the rabies cases in our country, or is this just the uh, hogwash?
See, population control is definitely important. That's true because if the city has too many dogs, so there will be conflict. There will be competition for food. They will go on searching for food, so there will be competition. Just like any animals, they have fight for the territories. So that will be here also will be there. Dogs will fight for the territories. So population control is definitely important. But at the same time, there should be rabies transmission control also, because after all, it's a one health. The environment, the animal health, and human health, they all overlap. So all should go hand in hand.
Right. Very true, sir. I mean, all of us as being practitioners, we have come across multiple bites. And in the beginning of the career, and I was thinking, why do we have to vaccinate when we know the epidemiology, when we know only certain dogs have uh, the virus in itself? But then, as we went on reading the reports, as we went on seeing the cases, we all really got wizened up.
Of course, this is just awareness. I think everybody must be aware. There is nothing can be compromised as far as self protection goes. You be protected yourself, then you do it. Be aware. That's all. And if you love the animals, arrange for their vaccination also. Not only food, not only shelter, but vaccination also. That's so important.
Yeah. I mean, you can. We should, as a IAP, should propose a strong message to the Supreme Court or a government of India, saying that if you have any of the legal tangles, whatever it is, we should be proactive in bumping up
Absolutely.
the vaccinations and as well as vaccinating the dogs, not the humans. Yeah. Thank you, sir. Thank you so much, sir. It was such a fantastic talk. I cannot imagine anybody doing a better job than you for this. So I'm so grateful to you, sir.
Pleasure to be with you and pleasure to be in this platform. Thank you so much.
My pleasure, sir. Thank you so much, sir.
Thank you.